we're going to talk a little bit about the impact of global health programs, especially focused on diagnostics in Peru. So it's been like 10 years now since I've been getting involved in global health programs. As mentioned before, the initial programs were called International Health, now they are called Global Health. So I will focus my talk basically on the accomplishments of global health programs in Peru. So these global health programs just put together different fields of study, so the epidemiology, the prevention, the training, so putting more multidisciplinary studies together, multidisciplinary also professions. So we are making our best, I guess, especially with U.S. researchers in Peru, like Brandon. There are a couple of things very important I want to show you later, but there are tons of studies running across the country that are coming with nice accomplishments through the time. So this is Peru. So for those of you that don't know where is Peru, Peru is in South America. It's becoming an important country because its food is very well known around the world. But we have a lot of attractions, a lot of wonders. We have nice beaches in the north. We have the capital, which is nice buildings there, colonial buildings. We have nice canyons in the south. So we have the jungle. So we have Machu Picchu, which is maybe the most famous building there. And we also have the Titicaca Lake. So this is an amazing country. But as an amazing country, also we have many threats. So it's across the country. So if we go to the north, where the nice beaches were, we have a lot of infections. So we have very high prevalence of dengue and malaria. And if we go to Lima, which is a very crowded place, 10 million people, third part of Peruvian population lives in Lima. So we have tons of tuberculosis, and the HIV epidemic is very high in some part of the capital. And if we go to the south, we have Chagas disease. And if we take a look at the jungle, we have more malaria, more dengue, we have Bartonella in Cusco, and we have a big problem of pneumonia across the lake Titicaca. So we have many threats and many wonders at the same time. So as a public health practitioner, we have to work on different stuff, different things across the country, facing different cultures and different languages, because our official language is Spanish, but here in the jungle we have almost 100 different languages, native languages. So it's very difficult to work with them. So we have like 2 different languages in the highlands, and maybe most of the people speak Spanish, but we have to face where the real problems are, where the people doesn't even speak Spanish. So, for starting with my presentation, I would say that to prevent and control, which is one of the main goals of the global health, we need to know where the infection is. So we did a couple of studies basically on STIs and HIV to know where the infection is, because normally the infection is in the hospital. So when we see a sick person, the sick person comes to the hospital because they have symptoms or they have some signs of the disease. It's easy work for us. But the problem is out there when the people is sick and they don't know they are sick, or they don't know they have an infection. So this is, for example, syphilis. So using this penis with this ulcer here it's very notable. So you can see it. But when syphilis happens in the throat, in the mouth, in the genital area, or maybe in the anus, you can see it. It's very difficult. And if it's not painful, you can feel it. It's difficult. So sometimes people is infected with syphilis and they don't know they are. So we need to go out there and look for the people that has syphilis, being men or being women. This is the bag. It's a very primitive bag. So it's maybe the most primitive bacteria we know that cause disease in humans now. It's a very simple bacteria. It can't survive without a human. It needs to be inside of the body to survive. So we know about syphilis that in Peru, this epidemic is very well known that it's concentrated in MSM and also in trans population. So, but also it's affecting pregnant women. So we know what is the problem. And we know what is the problem because we do a couple of studies. We did a national surveillance between 1996 and 2002, and we found a very high prevalence among MSM. It's 16%. It means that like 2 from 16 people from 100 has the disease or has the infection. But we look for symptoms, they don't have symptoms. So those 16 people doesn't know they have syphilis. So that's a huge problem. So we did another study 1 year ago with Alfonso Silva, which is a partner of our office. So we found a new prevalence. So we've been thinking that the prevalence was decreasing, but we found last year that actually the prevalence is higher, 23%, it is 1 in 4 people in the trans population or the MSM population is infected with syphilis in Lima. So, and also we found that we have high rates of reinfection. We found the people infected, we gave them treatment, and after 3 months they are supposed to be cured. They come back to the hospital and we check for the test for syphilis and they are still infected. So what happened? We don't know. The treatment is not working, is one possible question. The other question could be the bug maybe has a mutation, so the medication is not affecting the bug anymore. So maybe they got reinfected, or maybe they need an increased doses of the medication. So we don't know yet. So, but something is happening. So this is a very high rate of reinfection. And this is part of the study we got funded this year, the R1 that Brandon was mentioned. So we're going to explore what is going on among the population infected with syphilis that is becoming reinfected so easily. We also have that MSM has the highest prevalence of HIV in Peru. It's around 14–15%. So from those people infected with syphilis, we have like many of them are living also with HIV. So something is happening. So there is some relationship we already know between HIV and syphilis. So it's like the story of the chicken and the egg. We don't know who is first. So in this case, we are going to explore which is fair, is the syphilis or is the HIV. And we are not going to explore only the behaviors. We are only going, as we see later, to explore what's going on in the organism. I mean, is there an immunological problem? Is there a behavior problem? So we need to know that, and we are going to research that. So this is a primary health facility laboratory in Peru. So this is, I always show these pictures since last year because this is very close to the most finest neighborhood in Lima. So everyone saw the big hospital close to the main square, but 3 blocks from the main square, this is the primary health center. Just looks like very poor laboratory. So you can see they don't have a computer, so they have a writer machine. Like those machines died like 30 years ago maybe, but they still have it. So in this kind of lab, they can't perform modern tests. It's very difficult. So it's hard to, so that's why I want to point my presentation on the use of rapid tests. So because what? Because syphilis has a very ancient test. It's a very ancient disease using a very ancient test. This test has almost 100 years. So we're still using it. There is no modernization for this test. So we are still using the VDRL, which means Venereal Disease Research Laboratories, and the RPR So they are the most widely known and used tests for syphilis, and you can see the sensitivity of those tests. Both have the same sensitivity. So in primary syphilis is 80%. So, and knowing that from the infected people, only 30% has symptoms, so I mean 70% doesn't know that they have syphilis, and from those 30% that has symptoms, only 20 of those 30% has an ulcer, so a real ulcer. So it's only few people we can detect with those tests. So we need better tests for diagnosis syphilis. And besides its cost, because this test is very cheap, it's like less than $1 each test. So, and it's very simple to do. It's still unreachable in many public health facilities because it needs a couple of equipment for performing the test. So we need a rotator, we need electricity, we need an incubator, so we need a refrigerator. It's kind of difficult in some places. So we have rapid tests. So we have two kind of rapid tests that can be used for diagnosis syphilis, the DOT ELISA. So the ELISA is a regular test that we use to perform with machines in the lab. But there is one rapid test called DOT ELISA, and we have the immunochromatography, which is another test. I will show you a picture later. So both tests are very good tests. So, but the problem with those tests is that they don't differentiate recent for latent infection. That's very important in syphilis, because recent infection means you got infected maybe in the last 6 months. Latent infection maybe means that you got infected in several years ago. It makes a huge difference. If you are recently infected, so it's easy for you to spread the disease or the infection to your couples. If you get the disease maybe 2 or 3 years before, maybe you can spread the infection, but the neurological problems in your body are going to be very, very bad. So you can die from syphilis. So it's important to know in which stage of the disease you are. And also the treatment depends on the stage of the disease. So you have recent syphilis infection, 1 shot of penicillin will cure you. But you have latent syphilis, you need 3 shots of penicillin. So it makes a difference in the treatment. So, and these tests, those rapid tests can be used, not for everybody, but can be used for antenatal care and also for epidemiology studies. So for antenatal care, so there are many studies that has proved that are very useful actually. So because in many countries around the world, pregnant women doesn't go to control their pregnancy during the 9 months of the duration of the pregnancy. They just go the last minute so to get birth. So with a rapid test, you can know if they have syphilis, and you can give a shot of penicillin and take action for the new baby. So, but we still don't know the performance of this test in very early syphilis because the lack of antibodies in the body. So this is a cool study that was done in Peru a few years ago. So to show the utility of this rapid test, so we went to the jungle, so very far away from the main city. So because people normally think that HIV is a very urban disease, it's only big cities. So nothing is happening out there in the jungle. So because those people live isolated, so they don't have HIV. That's what we thought. So there was a case of death related to AIDS in this community very far away from in the Peruvian jungle. This community is called Chayahuita. This community is like 12 hours by boat from the main city, or 24 hours hiking from the nearest hospital. So it's very far away. So it's in the middle of the jungle. So, and this death occurs there. So what's going on there? Why someone has died from AIDS in the middle of the jungle? So we explored what happened, and we found after an epidemiological study that there were a lot of HIV there. So you can see more than one case of HIV. And we also tested for syphilis, so we found syphilis. So what's going on in the community? So the investigators did some interviews, and those people were farmers, and they were selling their products in the main cities. So they transport their products to the main cities. Once with the money in hand, they were to the brothels to look for some prostitutes, have sex without protection, and they got syphilis and they got HIV. So they going back to their towns, to their communities, and spread the infection to the other members of the community, especially their wives. So because they don't use condoms. So it's a problem. It was in one community, so the university took the lead and performed another study, but not only in that community, but also including 4 communities in the Amazon region. So recruiting almost 300 people, testing HIV and syphilis using rapid tests, so the results were delivered in 5 minutes to the people. So what they found was that 6 new cases of HIV in the jungle, which is rare, never reported. So now the government has taken advantage of that finding, and they have a program for, it's like a public health program. So there are people going to the communities teaching about HIV prevention, about using condom, and about rapid testing for HIV and syphilis. So we also did this project, which is a NIH-funded project. We call it Comunidades Positivas, or positive communities. This is communities where we have higher prevalences of HIV, like 20–25%. So especially MSM. And we randomized this study in 4 blocks. We have one block for control, one block for Comunidades Positivas, which was a social intervention where we build a community center. In this community center, we give advice to the population about HIV prevention and condom use. And we also have this arm called MMC, which is improvement management of contacts. It's like EPT, but improved. We also have an arm with a mix of both, Comunidades Positivas and EPT. And we put in the MMC, we put mobile teams, no, with rapid tests on hand for testing for syphilis and HIV, and also offer rapid treatment for syphilis in case we found any case there. So we put these advertisements on the streets. Sin condón ya fuiste in Spanish, which means in English, without condom you are done. So every time the people on the street see that advertisement, they know there were a mobile team, maybe in a bar or maybe in a pool place, where someone is doing HIV and syphilis testing and also offering condoms for free. So this is another approach. So we went to the field and we increased the treatments for syphilis in 1 or 2 months. So if the nearest health center has like 100 tests done for syphilis in 1 month, the next month after the mobile team goes to the field, we have 300 or 400 tests. So it increases the rates of people tested for syphilis and also increases the rates of people treated for syphilis using rapid tests and using this communicational campaign on the streets. We also put these stickers on the glasses they use for drinking beer. So you went to a bar and you have a glass of beer, you could see the advertisement of the program. So it was cool, actually. And this is a test. It's a very easy test. You can put here in this rapid test a drop of blood, and after 2 or 3 minutes you can get the result of your syphilis or HIV test. So it's very, very easy, very simple. There is another project I want to just talk a little bit because it's not our project actually. It's a project from the Dean of School of Public Health in Peru, Dr. Garcia. And she's doing this project called CISNE Project. I want to highlight that this project is advocated to eliminate the neonatal syphilis in Peru. So the idea is to offer free rapid testing for syphilis to all pregnant women that can afford to go to the health center. So we are knocking doors in different neighborhoods, asking for pregnant women. If there are some pregnant women, we offer them free syphilis rapid testing. So, as you saw, rapid syphilis testing could help with many things. With the early detection, so the laboratory diagnosis can give appropriate treatment for the people who is infected. So, but this needs to be scaled up in different public services, not only in big cities, but also in cities that are far away from the main. So we need to put those tests also in antenatal care or during the pregnancy, especially in the first and third trimester. We found in another study that many pregnant women are at risk of syphilis because of their husbands. So they are pregnant, and especially during the third trimester, the husband just go away, found another woman or maybe another man, so have sex without protection, came back home, maybe sometimes with a couple of years inside, have sex with their wife, who's pregnant, and give them syphilis. So this is a huge problem, especially in some villages. So that's why we recommend to use syphilis tests in the first and also in the third semester of the pregnancy. We also need to test in contact. So this is one thing it's very difficult to work because, especially with MSN, when you ask them, how many sexual partners do you have in the last 2 months, for example? And they said 10. So it's difficult to reach 10. They don't want them to know they have syphilis, especially 10 different people. So it's kind of hard. So we're still thinking yet how to deal with that. We also need new diagnostic platform, especially for groups of people with high rates of infection. So especially non-invasive tests like maybe using saliva or using urine or different sorts of samples. So we are trying to work on that. Once we know where the infection is, what's the population affected, we need the right tools where needed. So, and this is, I'm going to show you another example from Cayetano, which is TBC. So TB in Peru is a very well-known issue. So during the 90s, you can read the papers, Peru was the most successful country on DOT strategy implementation. It was a recommendation of WHO. So we decreased the incidence of TB from more than 200 cases to almost 100 cases per 100,000 people in 9 years. It was a very successful program. So, but by the end of the 90s, the program covered almost 100% of the people, and almost 100% was cured. So if they were treated, they were cured. So it was a success. But the problem is resistance to the medication. That's the new problem we are dealing with. So we are having resistance to the regular dose, and also we are having XDR, which is worse. So this is the problem we are working with in Peru. So there are Partners in Health has a huge project in Peru now. They are recruiting like 30,000 people to know what's the epidemiology of multi-drug resistance tuberculosis. So TB diagnosis is very easy. So you can do the screening with a very cheap and easy test, which is the sputum smear microscopy test. It's very easy to do, and it can be performed in every lab. So even in the lab you saw in the picture before. So it's very easy. So, but the problem is resistance. So we don't have any rapid test resistance. So we still need very high-tech public health laboratories for detect resistance on the patients we have. So we're still dealing with that too. So our university developed a couple of years ago this new test, the MODS, which is famous. It's a microscopic observation drug susceptibility test, which is called MODS. This test is for determining resistance to isoniazid and rifampicin in 10 days, which is very cool because normally the culture for TB takes like 30 to 60 days. That's what the manual said. And after the culture, you need to do the resistance test, which takes like 20 to 30 days. So in total, it's like 4 to 6 months to get a diagnosis of resistance. So it's a very long time. But this new test can give you results in 10 days. So culture and susceptibility test very, very fast. So, but still expensive because you need a very huge, expensive microscope. And you need to do culture of TB, but works very well. So, and the MOD was developed in a research laboratory. So this idea, a few years ago, the university comes with this idea that we need to spread the MODs. Instead of spread TB, we need to spread the MODs. So from the research lab, spread the MODs where it is needed. So the university put together different actors. So the university here with the Peruvian National Institute of Health, the National Strategy for Preventing Tuberculosis, the National TB Program, which is a different program here, and all the regional laboratories together. So they build a new protocol to translate this technology from the university to the regional laboratories with the collaboration of the national authorities. So this is actually a very huge project to transfer technology from the academia to the public health side. So and this was the beginning. So the university needed to be sure that when they transfer the technology to the public health laboratories, they will perform the technique very well as in the university. So they did a validation, so where they train, the university train all the staff in the regional labs, giving them some positive sputums and negative sputums. And the National Institute of Health Laboratories did the comparison of results, so among the regional labs and the reference lab. So if the regional lab met the criteria, so they were able to perform the most, and we are in the process of transferring this technology to the regional labs now. I will skip this because I'm in a hurry now. So once we know where the infection is, where the technology is needed, we need more people trained like you. So we need trained people to do the things in the field. So this is just for you to remember that there are no heroes in the lab. It's only people working. There are no heroes in public health in general. There's people working. So people outside in the street, they would never know who is a public health practitioner. So we started different collaboration thinking on that, training people. So we started like 10 years ago with this collaboration between UPCH and UCLA in 1999. So this initial project was called the CISNE Project. We respond to an RFA from NIMH to do an HIV and STD prevention trial in different countries. It was like 8-year study that includes different vaccines. At that time, the university didn't have an STI laboratory, so we performed all the tests in the US Navy laboratory down there in Peru. So, but at the end of the project, we come up with this idea to build a new laboratory. So we built the Laboratory of Sexual Health that now is doing another studies in collaboration with different institutions, and UCI is included with Brandon. So this is the laboratory now. It's a very big laboratory with many students and many people working there, and we have some faculty visitors that come from another country just to learn what we're doing there. So we have a lot of almost 20 scientists from over the world that came in the last 6 years to learn what we're doing in the laboratory. This is the new project that Brandon was talking about. This is the Syphilis project. This is a new collaboration between like 5 different institutions. So that will start in a few weeks. So we are trying to understand the relationship between the host, the pathogen, and the environment for syphilis. So we are trying to develop better strategies for high-risk population. So developing new algorithms, new diagnostics, understanding the immunologic response to the infection, and trying to understand also the change in the pathogen, maybe the mutations or maybe some variants of the bug that are affecting our population. So we are putting in the triangle of infection, also we are exploring the Facebook, the email, the SMS systems, just to understand what's going on in the environment that makes the people more vulnerable to syphilis. We are also exploring what are the mutations and if there is any resistance hanging around, or what's going on in the body of the people infected, if they have some deficiencies in immune response or they have problems for diagnosis. Almost done. This was a last week meeting. We began in Brazil in a meeting. This is very important because now we are vocated to diagnostics in global health. So, and all the Latin American countries meeting together last week in Brazil, or 2 weeks ago in Brazil, and this idea came up with the support of the London School of Hygiene and Tropical Medicine to put together all the Latin American countries to build an effort to develop more diagnostic tools for public health, especially for infectious diseases. So all the group meet together, and one of the first steps we are taking is a survey that's conducted now in Latin America about the needs, about the challenges, and about the regulations regarding rapid diagnostics in the region, especially for infectious diseases. So finally, what are we doing at this moment? So this is the things we are doing at this moment in our laboratory. So we are developing tests with veterinarian student, which is he's doing a new syphilis test based on llama antibodies for simultaneous detection of IgG and IgM for syphilis, which is a very cool study because usually the antibodies are produced in mice or in rabbits, but you can produce more antibodies in llama and smaller antibodies, which is maybe cooler than the regular antibodies. We are trying to work on new system for concentrated antibodies in saliva for syphilis diagnostics. We performed the first step of the study. It went wrong, but we are now in the second step doing some modifications. So we are also developing an in-house PCR for gonorrhea diagnostics, especially for resistance to quinolones. We just finished the validation of different HIV point-of-care tests. The paper is in press. And also we have a student doing a PCR test for detecting and differentiate at the same time HSV1 and 2 in blood. So those are the challenges we are facing. So we guess we need to develop not only new diagnostics but also new resistant tests, which are very important now. So we have emerging resistant different medications. So we want people for implementing algorithms for study outbreaks and epidemiologic surveillance, which is important. We need to improve our local public health programs, so transferring the technology from the academia to the public health side. So we need to participate with other low-income countries in the development and validation of new rapid diagnostic technology, because more of the technologies we're using are validated in developed countries. And we get those technologies, it doesn't work in low-income countries. There's a different behavior, it's a different epidemiology, it's a different patterns of the diseases. And we also need to increase the investment in diagnostic within. So we have set of opportunities. This meeting, I guess, is a good opportunity to meet and talk about. So we have the opportunity to do more operational studies, more clinical trials, to work more on policy, also to work more on developing new facilities for new diagnostics tools. And this is my link of diagnostics for global health. So in the future, hopefully we can have these tests. It's spread all over the world. And for developed countries, it's the same test, but in a cool machine maybe. But for low-income countries, it's the same test, but maybe transported with this car by a horse or a mule, but it's the same test for everyone. So, thank you. You have any questions?
Thank you. So just so we appreciate the history of technology development and its applications, the original test for syphilis, VDRL and RPR, were they based on antibodies? So the ELISA one that you developed certainly detects antibodies very quickly.
Yeah.
But what is the impediment that innovation advanced? That is, these old methods, what was detected?
Yeah, in syphilis there are two kinds of methods. One are called treponemal methods, and the other one are called non-treponemal. Treponemal methods detects real antibodies against the bacteria, and non-treponemal detects not real antibodies but also related antibodies. So there are antibodies that are kind of allergic antibodies that are produced in the body against some proteins that are similar in the bacteria. So it's like inflammatory proteins. So the final diagnosis should be made with a treponemal test. So ELISA, rapid test, FTA or TPPA are treponemal tests. So why we are still using RPR and VDRL? Because they are cheap. They can be performed in every hospital and every public health facility, but they need electricity, they need equipment, so they cannot be performed on the field. So where maybe most of the people with syphilis live. What happened in Peru is that people doesn't behave like if they feel sick, they don't go to the hospital. Especially men, they never go to the hospital. So, and they are maybe the most affected population. And we also are dealing with discrimination and stigma issues, because most of them are MSM. And so when they show up in the health facilities, they are discriminated. So they feel the stigma and they don't go, so they do prefer to be at home sick.
Thank you. Part of the reason I asked was, I know you got a chance to meet today with Cheryl Krugman from Stanford. Last night she gave a talk on Lyme disease, and the controversy was also related to diagnostics and comparing diagnostics, different tests and symptoms, which also carries some stigma.
Yeah.
And it's a huge controversy in the field, but I think syphilis is hopefully more straightforward, that if you have a good test that detects the presence of the organism, then immediately antibiotic therapy is given. So you don't have vague symptoms.
Yeah.
But you have carrier status, which may be a problem.
Yeah.
And then, so the next question is, in the remote areas, when you actually find somebody who tests positive, what kind of follow-up? Because in developing countries, that's a bigger challenge to make sure people take their medicine, to have medical care in those kinds of remote locations.
Yeah, this is a very interesting question because it's very challenging. So what we do is to give, to choose one dose treatment. So when you find a new case of syphilis, you treat them as if were recent syphilis. So you only need 1 shot of penicillin, 2.4 million, so that's enough. So we came back 3 months later. If the titer is decreased or the test is negative, we consider it cured. If it's the same, we need to give them 3 shots once a week. So we have to stay there for 3 weeks.
HIV is more complicated.
HIV is more complicated. Besides, the treatment for HIV is free in the country. We still have a lot of people not receiving treatment, basically because of the stigma and discrimination.
Thanks. Any other questions? Okay. Well,
Okay, well,
big
thank you.
round. Thank you very much.
Thank you.